Welcome back to EASDtv. Now, today we're talking precision medicine, and I've got two people with me today who have been working on a presentation of precision medicine, which I know was very well attended and very much commented on. So, Paul Franks and Robert Wagner, welcome to the EASDtv studio. Now, Paul, we've been talking about precision medicine in diabetes for a very, very long time. What do we mean exactly by precision medicine here, and have we really got it yet?
So one of the challenges, I think, with precision medicine is understanding what those words mean. And some people use the same words to mean different things, and some people mean different things when they use the same words. The simplest way of thinking about precision medicine is just that it's a process through which we reduce error in medical decision making and health advice. But of course, many people think about genetics as part of that process of reducing that error. I think so far there's been some wonderful research done in the complex forms of diabetes, but most translational opportunities have come with the monogenic forms of diabetes to date.
So are we talking just stratification essentially, something that actually physicians have done for a very long time?
Well, so certainly the stratification of populations based on risk factors, as you say, has been around for a long time, and that does help define subgroups of the population at higher risk who might be worthy of an early intervention, and that to me is part of the process of being more precise in medical decision making. But the question is, can we go much further than that? And that's really what the promise of precision medicine holds. And that's something that I think, with complex forms of diabetes, we're still trying to figure that out, to be perfectly honest.
Robert, what does precision medicine mean to you?
So I think it is only a recent development in diabetes therapy that we have the options to try to apply precision medicine. Just a couple of years ago, you didn't have too many options to treat diabetes differently in a precise way. And now you have different kinds of medications, and if you compute the possible combinations in which way specific drugs can be combined, you come up to a very high number. So you have the option to optimize treatment by combining the right drugs for every patient. And a physician does precision medicine all the time because he's treating exactly one patient, but based on his or her experience, based on the clinical recommendations which are ruling in the field. And we don't have precision recommendations in diabetes treatment yet. And we have to develop this framework where we can decide for which kind of patient, which kind of drug is the optimum therapy.
Now, what we see in oncology, for example, is we see very large trials, and you'll see analysis of small subgroups, and then you'll get a drug that is for a particular small subgroup, and then plus they'll get other things on top. Is that the kind of approach that you think is more likely in diabetes?
I think it's unlikely that we'll be able to mimic what's been done in oncology, mainly because the diseases are just fundamentally different from a biological standpoint, where you can detect somatic mutations sometimes in cancer, and you can target drugs at those. That's not how most diseases work beyond cancers. I think what we do have today in terms of the sort of the brightest opportunities for precision diabetes medicine with complex type 2 diabetes is what's been shown through the TRIMASTER trial, which is actually just very simple stratification on kidney function and body mass index, and then demonstrating that three different classes of diabetes medications perform differently depending on those stratifications, and indeed that the patients who receive the stratified recommendations do better. They have better HbA1c outcomes, but they also prefer the medication they're prescribed on that basis. So that's a really simple type of stratification that goes beyond current guidelines and takes us a little bit further along the path towards precise diabetes medicine.
What about precision prevention, which is another phrase that keeps coming up, to predict people who might develop diabetes or particular complications?
So I think that alone, based on the huge number of people who have pre-diabetes worldwide. In the US, it's about 40% of the adult population. For this condition, it's actually not a disease. It's not. It's just a.
It's just being American.
Dysglycemia. It's the beginning of diabetes. Some won't develop diabetes, but based on these huge numbers, you have to find ways for precision prevention to act on those who have the highest risk to develop not only diabetes but even more complications, because diabetes itself can have mild forms, mild courses which will remain silent, and some of them will never lead to complications. And in diabetes, complications hurt. They cause the suffering of the patients, diabetic foot syndrome, retinopathy, nephropathy, and not the hyperglycemia itself. So I think we are looking for the strata which are at the highest risk to get these complications. We have to focus on our prevention efforts, which are expensive and very laborious, on these groups.
That's interesting. I wonder whether COVID-19 now plays into that, because we are seeing quite a large number of people who've had COVID then go on to have diabetes. Is that something that you might follow up?
I think it's not yet completely clear if these associations are real associations or just statistical bias. So if COVID leads to later higher risk of later diabetes, and it's the disease itself or the sequels of COVID themselves, it's not quite clear. We know that those who have diabetes or those who have obesity and metabolic syndrome develop more severe forms of COVID, and that's why it's possible that we recognize these persons as having COVID more than those who do not have these risks. And in the data, in the studies which investigated this association, you can never completely rule out this confounding, this additional confounding.
But it's also the case that people with diabetes who have infections, they tend to not do so well with those infections, and that's well known. So I suspect people with pre-diabetes with infections will also have a response that might push them over the edge of diabetes. And the point I think that you started with was that maybe it just preempts a type of diabetes that would come later when somebody has a COVID infection.
So it accelerates it effectively.
Pushes it forwards a bit, maybe.
So where do you think precision medicine is going? There's been a lot of hype around precision medicine. What's the reality going to be, say, in the next 5 to 10 years?
So, I think ultimately precision medicine is not going to be the revolution in medicine that many people hope that it might be. It will be part of the evolution of medicine. It will move medicine along the path a bit further and maybe a little bit faster than it would do otherwise, but it's not going to change things whole scale. And indeed, evidence-based medicine, contemporary evidence-based medicine does work. It just doesn't work as well as we'd like it to. If you take diabetes prevention as an example and you look at the diabetes prevention program, the impact that lifestyle intervention had on the progression to type 2 diabetes in people at high risk was only about a 36-month delay, and metformin only delayed the onset by about 18 months. So contemporary sort of lifestyle recommendations, they help, but they certainly don't do, they don't completely stop a disease like diabetes in its tracks. So I think precision medicine might mean that we can do things a little bit better and have a longer lead time on the prevention of diabetes.
Robert, are you more enthusiastic about the future for precision medicine in diabetes?
Actually, I agree with Paul that it probably won't revolutionize diabetes treatment in the close future. And I also just have to repeat that physicians try to act precisely. So based on their experience and who they know the patient, they know the family, the social background, and and they always optimize treatment, try optimizing treatment. With our research, we would like to provide some evidence and guides to do this, and this will probably slowly change the future. We have just started it, and we need to prove what we have found. We need prospective studies. We have to try these concepts in trials, in studies, try them out, and see how they work before applying.
So thank you both very much. So precision medicine inching slowly into the future is, I think, the message I heard, but nevertheless it was a really interesting session, and it is available online, so please do go and have a look at it, because I think you'll find it fascinating despite the slightly downplaying that's going on here. Bye for now.